Up next, we have Dr. Esther Knapp. She's a pediatric hematologist and oncologist here at Norton Children's Hospital. And she's also an assistant professor of pediatrics at the University of Louisville and chair of our Norton Children's Hospital Ethics Committee. Welcome, Dr. Knapp.
Hi, everyone. Okay, I am going to stick with the time schedule because I have been informed Dr. Schumann can be very scary if she needs to be. I'm going to talk briefly about deception regarding children. I'm not kind of like what Dr. Salter was saying, I'm not here to tell you the right thing to do, which sometimes disappoints people when they hear that. But what are some of the reasons why we may or may not think it justifiable to deceive children? Oh, I have to use the clicker. Okay. No one's magically doing it for me. So in the care of children, we have the patient who may or may not, in pediatrics, sometimes they're under the age of 18, but sometimes they're 18 or older. We have parents, family members, guardians who may or may not be biological parents. We have all the different members of the medical team and support staff that help care for children. Just to review, in pediatrics, the law presumes that in most cases, the parent or legal guardian just makes decisions on behalf of children with a few exceptions, and the law can differ from state to state. Now, in some situations, if the parent or guardian is making decisions that we do not think are in the best interest of the child or not helping the child or maybe even actively harming the child, there are legal avenues for disagreeing with the parents, but that can get kind of messy and that's not always necessarily set in stone. Okay. So why would you lie to a child? Well, if you've ever had a child or you will know what I'm talking about. I lie to my children all the time. Don't tell them I said that. Oh, Target is closed right now. Sorry. Or you did a really great job. They are horrible at basketball. That is truthful. Or we're almost there. It's a road trip. Yeah, 5 more minutes. And we're only in Alabama. And sometimes it's not just for our own convenience, but sometimes we might say, well, your dad really did want to come visit this weekend. I know he told you he was going to take you to the movies, but something came up. It was completely not his fault. And that's why he's not here. So sometimes we do these things to preserve relationships, for example. So what are some of the reasons for deception in medical care of children? Well, sometimes a large consideration is maintaining therapeutic relationships with the family. I think it's really hard sometimes to describe how onerous it becomes when the family disagrees with the medical team or when the family is requesting something that the medical team does not want to offer or does not want to do. It really makes things so difficult, and it colors the entire interaction with the child, with the family, every minute, every day. It makes the doctor's job harder. It makes the nurse's job harder. And so we really do try to avoid that. And sometimes in our efforts to avoid that type of conflict, we will give a little bit. And sometimes those seem like minor concessions, and sometimes they can be a bit bigger. But, you know, essentially no one wins when we say, okay, well, that's it. We're calling CPS and we're going to try to take custody away of your child. Sometimes that is necessary, but we really try to avoid that if possible. Sometimes revealing truths in the medical setting could lead to certain harms, whether they be, and there's different types of harms. Let's say that, you know, in the world of oncology and stem cell transplant, we will often do genetic testing on a patient and their family members to see, is one of your siblings or one of your parents a potential stem cell donor for a bone marrow transplant? Well, sometimes we find things like your dad is not who, the person you call your father is not your biological father. Is it our obligation to say that, and to whom? And do we try to pull someone aside? That wasn't the reason why we did the testing. We did not discuss this, say, at the time. So in that type of situation, am I obligated to volunteer that information? Well, that becomes tricky. Sometimes you may withhold the truth or engage in deception in order to decrease anxiety on the part of a patient and or family members. Sometimes we want to, particularly relevant in oncology, but other aspects of medicine, let's say we find genetic information that actually your tumor is less treatable than we initially thought it was. It's not going to change anything with your treatment. Do you need to know that? Does your child need to know that? These are questions that sometimes come up. We get in pediatric oncology, we get asked a lot, especially in the beginning when, let's say, parents have just found out that their child has cancer. Could you not tell her, or could you not use the word cancer? Or can you give me a little bit of time? I want to explain it myself. Or could you just tell her it's medicine, not chemotherapy? Can you not use that word? So we get a lot of those types of requests, and it's sometimes, difficult to navigate. Sometimes parents ask about, well, do you have the results from the biopsy yet? And maybe the pathologist called me 5 minutes ago and said, hey, it's really looking like this type of leukemia, but I'm going to do one more set of stains and then the report will be finalized tomorrow. Until those results are in writing, I never tell anyone anything, because, you make that mistake once, you'll never make it again. But, I'll tell the family, no, I don't have the results. Is that a lie? Kind of. I mean, so where do you draw that line? So there are some reasons why you might deceive a family or deceive a child at the family's request, but what are some issues with deception? Dramatic pause. Nope, slide didn't advance. Well, mistrust, especially when we find ourselves in the position of potentially lying to children. Anyone who works in pediatrics probably knows those kids, they are always, always smarter than us. They know when we're deceiving them. They seem to know everything. And all of our attempts to outsmart them are always foiled. So I think you want to be really careful about lying to children or telling them things that aren't true, or leaving out information. And I'll get to that in a minute, sort of strategies for dealing with that. But kids are smart. And once you've eroded the trust of a child or of a family member, it is really difficult to sort of earn that back. And, as the part of the therapeutic relationship between a patient or a family member and the medical team relies on this trustworthiness. So if you've already shown yourself to be someone who is not trustworthy, that potentially damages everything that comes later. So there are other reasons why you wouldn't want to lie to people. And we talked about autonomy and various ethical kind of principles that would apply here. There also is the consideration of the medical staff. I mean, there are so many people who take care of children. And sometimes if we say something to a child, let's say at the family's request, or withhold information, how does that affect the other members of the team? Let's say that decision is made by, a physician or the head of the ICU or a hospital administrator, but it's the nurse coming into that kid's room every day who has to, keep up this charade. For example, you might have a child who is actively dying, and let's say the family doesn't want the child to know that and asks the medical team not to share that information with the child. And let's say the child knows what's going on, he's completely cognitively intact. How does that affect the nurses and the other staff who have to go into this child's room every day and pretend like he's fine? That's very difficult. So there are a lot of people you need to consider, and a lot of different stakeholders in all of this. Okay, I'll share some cases just kind of to give you a little taste of some of the issues that can come up. I cannot make this stuff up. These are real cases with identifying information removed. But this is some of the stuff that we come across. So our first case, this was an actual ethics consult at Norton Children's Hospital. There was a teenage girl with a condition where she is born with XY chromosomes, but phenotypically is female. So her whole life, this girl has thought that she is female and she identifies as female. She required a gonadectomy, so a surgery, when she was around 15. And at the time, she was just told, hey, you have this problem, kind of a vague explanation. You have this problem with your internal organs and they need to be removed because you don't need them and they're harming you. So she was kind of left in the dark. So she was followed by the pediatric endocrinology team for many years. And at some point they said, okay, well, this girl's turning 18, so she's an adult now. And she was completely, cognitively intact and able to make her own decisions. But the parents said, well, we really don't want to tell her because, she's really anxious and we think that she's not going to do well with this information and we know what's best for her. And so they requested that the child not be informed. And just to cut right to the chase, essentially this got escalated to the point where the hospital instructed the parents that we will inform her by X date. And the parents said, okay, thank you. We're never coming back here again. And they left. And as far as I know, this woman is still unaware of her diagnosis. So not all of these cases have a happy sort of neat ending, unfortunately. A couple other cases just to briefly highlight there. We had a kid who had a bone tumor and he was undergoing surgery, and his legal guardians, who were his grandparents, said, well, he's very anxious. He acts out a lot and he gets really distressed. All this was true when things are just, upsetting to him. And can you just tell him that he's having pictures taken? And in this particular case, the surgeon did say that to the child. He said, you were having pictures taken. And in fact, and then he comes back from the operating room and has a scar and has postoperative pain. So, the child did figure out eventually what happened. And so that was another ethics consult because, there was the desire to accede to the family's wishes, but at the same time, is that fair to the child? Especially if it's, in this case, something he will find out the truth eventually. Okay, and then we had I'm sorry, I have not advanced the slides. The third case, again, this is a real life scenario. We had a teenage boy with pretty significant autism spectrum disorder. He had leukemia. There were several behavioral issues that came up over the course of his treatment, and he could get very physically aggressive. There were several incidents with staff. So people did not want to upset this young man. He became very fixated on the date of the end of his treatment. And long story short, his mom asked us to just pretend that he was still on chemotherapy. Because she said he's going to lose his mind if you tell him that his leukemia treatment has ended. He has this date in mind. That's not the correct date, but he seems very fixated on this date. And, all hell is going to break loose if you tell him. So no one told him. It was determined that would be the risks were too great in this case. So those are some real life scenarios, and hopefully this illustrates some of the complexities involved. Again, not telling you what the right or wrong thing is here, but there's a lot of different considerations that we have to weigh. And I think some tips that I think can be useful in these types of cases. For example, as a physician, sometimes I'll try to set expectations clear up front, and I'll say, I understand this is a difficult time. I'm happy to discuss further, but let me just tell you right now that if your child, who is X years old and capable of carrying on a conversation, if she asks me point blank, I am not going to lie to her. That is my personal practice as a physician. I do not lie to children because I find that is harmful in the following ways. And if you set that expectation up front, hopefully it kind of creates less stickiness later down the line. Sometimes, families might have requests on certain words that they don't want you to use. And sometimes, you can come to an agreement on, well, we're not going to use the word cancer, but we will explain X, Y, and Z. Sometimes we will set a time limit. Okay, well, we do want to tell our child, can you just give us a couple of days? We want to process this for ourselves. We would like to bring in a psychologist. We would like child life to be involved. And sometimes if there's a set amount of time, that's something we can work with. And, this is sort of a strategy I employ with my young children, but sometimes if you want them to do something, you pretend you're giving them a choice, and you are, but it's just between two options that you have pre-approved, would you like to eat your beans, or would you like to eat your broccoli? That kind of thing. So sometimes we'll say, well, we do need to tell your child, but would you like us to do it? Would you like to be the one to talk to your child? Tell me, what are your preferences? And giving the family some measure of control really is helpful and establishes that trust. Ethics consultation service, we are always available. Woo, woo, yep. Call us anytime. And then sometimes deferring to the risk legal department is helpful because, sometimes they can be the bad guy. You can say, well, our lawyers tell us that we have to disclose X, Y, and Z. Sorry, not up to me. I'm still your great doctor that you love, but thanks for me. So those are all the quick remarks. Oh, I'm sorry, I didn't advance this. That I have planned. I technically ran out of time, so maybe one or two questions.
At the end.
Oh, perfect. Yes, I got the look. Okay.
Thank you. Okay, our next speaker is Dr. Scott Williamson. He is the Robert H. Walkup Professor of Theological Ethics at Louisville Presbyterian Theological Seminary, where he has taught since 1997. Dr. Williamson holds a PhD in ethics from Yale University and is a member of the Home of the Innocents Ethics Committee. Welcome, Dr. Williamson.
Thank you. It's good to be here. I work at the intersection of ethics and culture. So I think a lot about the impact that cross-cultural difference and disagreements have on moral decisions. This evening, I am not presenting an argument. I'm presenting two observations and reflecting on those observations. My first observation is that higher levels of cross-cultural agreements correlate to better arguments for clinical deception that will have cross-cultural appeal. The opposite is also true. Where there's more cultural disagreement, even cultural conflict, the more difficult it will be to generate arguments for clinical deception that have cross-cultural appeal. My second observation is that cultural competence and cultural humility can be very helpful increasing cross-cultural agreements. So there's a way to try to move the needle toward the greater kinds of agreements that will be helpful when trying to do something like create an argument for clinical deception. I'm going to turn to a case, and the case that I turn to will be one that Dr. Salters has presented, a variation on a case for an autonomy-based argument for clinical deception. And before I get there, I want to say just a little bit about moral theory. I'm a visual person, and I want to show you a little bit about my style in doing ethics. First, if I were to map the moral terrain of normative ethics, or what should we do, I would first identify two poles. And then I would identify what I call points of moral interest in between those poles. So moral objectivism emphasizes what is universally binding in moral belief. Norms are absolute and cannot be justifiably overridden by any other norms. Moral relativism emphasizes the particularity of cultural context in moral belief. So each cultural group has its own distinct moral rules. Thank you. Distinct moral rules and norms that cannot be overridden by an appeal to what is universally binding. Most moral agents and ethicists are somewhere in between those two poles. I like to see the poles and feel the tension of them because it keeps me honest with myself, that I don't want to veer too far one way or the other. For example, in their classic treatise, you'll remember this, Principles of Biomedical Ethics, Tom Beauchamp and James Childress accept that there are fundamental moral precepts that enable cross-cultural judgment and also that enable the rejection of certain practices like enslavement, even when it has the approval of a certain cultural group. At the same time, however, they accept that there are significant cultural differences. Respect for autonomy, non-maleficence, beneficence, and justice are fundamental moral norms that are accepted by, as they say, all serious moral agents. But these moral norms are not absolute norms. In other words, they can be justifiably overridden by appeals to other fundamental moral norms. So in short, norms like the principle of veracity can be justifiably overridden on occasion by other fundamental norms like respect for autonomy. So instances of clinical deception might be morally appropriate. Now, in the case that I'm looking at, the patient has not explicitly stated, I do not want to be told any details related to my diagnosis. Rather, the patient's daughter has told the physician that her family typically does not share grave diagnoses with elders. Dr. Salters writes, this situation requires a strong justification or a stronger justification because while the daughter's report may indicate the patient's autonomous wish, it might instead reflect a family culture with which the particular patient does not identify. So the immediate moral concern, I think, for clinicians is the role of culture in the patient's moral decision-making process. Does the patient identify with the daughter's presentation of family culture? What values and beliefs might underlie the family culture's preferred decision-making style? And even if there is reason to believe that the daughter's presentation of family culture is acceptable to the patient, is that sufficient for an autonomy-based justification of clinical deception? Where culture is involved, moral decision-making is a tougher affair. And that's because the cultural context includes not only the family's culture, but also the physician's relationship with the patient and patient's family, the institutional culture, race, sex, religion, language, all of these factors can impact the moral decision-making process. Let me give you an example. A patient in his early 70s is experiencing confusion and is being given a cognitive test by a physician. It matters for this example that the patient is Black and the physician is white. The physician asks, do you know what year this is? The patient says, yes. The physician waits a few moments and then says, and the year is? And the patient responds, you didn't ask me what year this is. You asked me if I knew what year this is. racial difference showed up as a concern for the patient in this interaction in a way that made the physician-patient encounter more tense. Not wanting to open this Pandora's box, the physician said, okay, what year is this? The patient, however, felt unheard. If the cultural dynamic surrounding racial difference in this example is present in our case, then the appeal to family culture might not be sufficient for family-based justification for clinical deception. So in this slide, and I missed one. Here's where I want to be. In this slide, I'm reflecting on the experience that can result when the care team experiences a high degree of unity, perhaps based on a common organizational identity, but the physician and patient do not speak the same moral language. The result for some patients is often diminished trust in their care because they perceive that they are not being treated as respectfully or cared for as well as other patients. I use non-technical terms like cultural harmony in place of the more technical and precise term concordance. And I use dissonance in place of the more technical and precise term discordance. But the technical terms populate the medical literature. Take, for example, a 2018 study by Megan Johnson Shen, S-H-E-N, entitled The Effects of Race and Racial Concordance on Patient-Physician Communication, systematic review of the literature. Shen then defines a concordant visit as one in which a physician in a particular ethnicity, racial group saw a patient in the same race ethnic group. Shen and her contributors write, and I'm paraphrasing, results indicated that Black patients consistently experienced poorer communication, poorer information giving, poorer patient participation, and poorer participatory decision-making than white patients. So racial concordance was more clearly associated with better communication. There you are. So how does culture show up? Any number of ways that can complicate moral decision-making process. There's professional culture, right? What it means to be a healthcare professional. Organizational culture, the values and norms of a particular healthcare organization. There's occupational groupings and hierarchies. There's diversity of race, age, sex, religion, language, family culture. There are also automatic associations, unconscious biases. So to look at the picture, they look like they've each had 8 good hours of sleep. Just cultural or unity and diversity. But there are fault lines that are not visible in terms of how they encounter each other and their patients. And these cultural fault lines can become manifest in patterns of care. The question for us now is how culture might participate in healthcare quality improvement. And here's my second observation. 2 resources that can make a difference are cultural competence and cultural humility. Becoming culturally competent is a developmental process. To become effective in cross-cultural relations, requires, in the words of Terry Cross, assessment, vigilance, expansion, and adaptation. The assessment of cross-cultural relations, vigilance towards the dynamics that result from cultural difference, the expansion of cultural knowledge, and the adaptation of services to meet culturally unique needs. Cultural humility is a more recent conversation that's become more prominent largely because of the work of diversity, equity, inclusion, and belonging professionals. It's sometimes thought of as self-first approach to cultural difference because it begins with a realistic, ongoing self-appraisal. For example, what unconscious biases do I bring with me, and how can I become more aware of myself? It also works with vigilance towards existing power imbalances. Further, cultural humility promotes interest in another person's experience and curiosity and willingness to learn about cultural difference. Organizations can have both high levels of cultural harmony. For example, when healthcare professionals agree about, let's say, the shared culture, the values and norms of their organizational culture. But it can also have high levels of cultural dissonance, perhaps in the ways that minoritized populations perceive and act on health information. In terms of norms, cultural competence and cultural humility are two strategic resources for promoting greater cultural harmony. If the moral terrain is relatively free from cross-cultural obstructions, roadblocks, accidents, then there's greater likelihood of the broad-based agreements about moral values and norms, and greater likelihood of the flexibility necessary to justify instances of clinical deception in order to promote autonomy and beneficence.
Thank you. All right, our next speaker is Dr. Lauren Freeman. She's a professor of philosophy at the University of Louisville and director of the MA in Healthcare Ethics and an affiliated faculty member in the Department of Women's, Gender, and Sexuality Studies. Welcome, Dr. Freeman.
Can everyone hear me?
Yes.
All right. I know that I can't even see the timer because only two at the time. So thank you so much for having me. Thanks to Ron and Olivia for this wonderful invitation, to Valerie and Mary for all of the behind the scenes organizing, to all of the wonderful speakers, and to everybody. And I realize I'm toward the end, so I'm going to try and keep everybody awake. This is a conference on deception. So I feel like I have to be honest with you at the outset that I submitted the title for this talk about 6 months ago, before I had started this project. And so a better title for the talk is Deception, Ageism, and the Elderly, though there will be a brief appearance of microaggressions. I want to start with a land acknowledgement statement. So the land we occupy now, called Kentucky, is the homeland of more than 20 indigenous tribes, including peoples known as the Shawnee, the Cherokee, and the Osage. Indigenous peoples have lived on the land that's now called Louisville for over 12,000 years. And it's important to honor the land itself and to acknowledge the presence and influence of indigenous peoples of the past and the over 30,000 indigenous peoples living in Kentucky today. In particular, because I'm going to be talking a lot about injustices, and indigenous peoples have, of course, suffered and continue to suffer extreme injustices. So let's just take a moment to honor them. The learning objectives for today are to understand ageist discrimination that elderly patients experience in healthcare settings, to understand the intersectional ways that elderly patients are marginalized within and beyond healthcare settings, to consider various definitions of deception, to discuss some of the moral and practical harms of deceiving elderly patients, to discuss when deception might be justified, and very briefly to outline some tips for how to act in the face of complex moral situations involving elderly patients. And Ron doesn't think I'm going to be able to get through all of this in 15 minutes, but I'm going to prove you wrong. All right. So the structure of the presentation, I'll just briefly mention my social position, define who we're talking about when we're talking about the elderly, define ageism, problematize our definition of deception, and then of course to the question, what do we do? And I will follow all of the other speakers in line and say, I'm not going to give you concrete answers. So I'm keeping the bar low here. My social position is I'm a philosopher. I am not a healthcare professional. I always feel the need to say that in a room full of healthcare professionals. My research, however, does focus on oppression in healthcare contexts, and focusing on the elderly is a new project for me, so I'm really excited to begin this project with you. So the elderly, who are we talking about? Currently, 1 in 7 Americans is over the age of 65, and within the next 2 decades, that number will raise to 1 in 5 Americans. And that means that in 15 years, 73 million people will be considered elderly. In 30 years, 90 million people. Currently, healthcare of elderly patients accounts for 2/3 of the healthcare budget. I'm going to introduce a term to you. Many of you have probably heard the term intersectionality, though it's very often, especially in popular culture, incorrectly used. So I want to just make sure that we are all using the term correctly. Intersectionality is a concept or methodology that allows us to consider how race, gender, class, socioeconomic status, level of education, and other social identities converge to create unique forms of oppression. And I think it's really important that we engage in intersectional framework when we're talking about the elderly. So what do we mean by this? Older adults are not isolated from other healthcare disparities. So-called minority elders, which is a term that the AMA uses, I do not use that term, but will account for over 50% of the elderly in the next 25 to 30 years. They may suffer disproportionate burdens of illness and even early death. They may have greater rates of diabetes and cardiovascular disease, and this affects their health, but also, as we've spoken about, the health of their families and communities, especially if they're in lower socioeconomic situations and rural communities. Elderly patients who are members of other marginalized groups may have different attitudes about healthcare, as we just heard. So, for example, they may belong to a culture that holds taboos surrounding certain illnesses and diseases. They may have different conceptions of what causes disease, and they may hold different beliefs about treatment. Another example, LGBTQ+ elderly patients have a unique set of issues on account of their multiply marginalized identities. So they experience higher levels of illness, disability, and premature death than non-LGBTQ+ elders. And about 50% report a disability and 1/3 report depression. More than 20% do not disclose their gender identity to their physicians for a variety of fears, stigma, and shame. And this is importantly another kind of deception, and one that can be a matter of life and death. So switching gears a little bit, I want to introduce the concept of ageism, and it's something that we're probably all very familiar with. Ageism can be defined as systematic stereotyping and discrimination of people because they're old. So this refers to bias, prejudice, devaluation, negative attitudes, erroneous assumptions. Common stereotypes of the elderly are older people are frail and helpless, older people are incapable of living flourishing lives, older people are difficult and unpleasant, older people are cognitively deficient and thus cannot understand. And these implicit or explicit assumptions can lead to discrimination. For example, the reluctance to recognize and respect the needs of older adults, treating them less favorably than younger people. Nearly 1 in 5 Americans over the age of 50 say they've experienced discrimination in healthcare settings, which can result in inappropriate or inadequate care. And about 29% of respondents to the study that I'm citing here reported frequent healthcare discrimination and developed new or worsening disabilities over a 4-year period. To quote Dr. Carl Pilmer, there's no question that ageism affects care across a spectrum of care, including physicians, nurses, social workers, and others. In many cases, it results in an inclination to provide less care and attention. For example, older patients may not receive certain procedures because they're perceived as lower priority. So ageism can be overt, right? We saw rationing of medical care in the pandemic. And embedded in such plans is a value judgment, namely that young people's lives are more valuable because presumably they have more years left to live. Age bias in patient care has the implication then of devaluing older people's lives. Ageism can also be systemic. So older people may be excluded from research studies, which skews the knowledge we have. Older patients might be shunted off to physicians or other healthcare professionals who have limited knowledge of gerontology and less experience with treating older patients. Ageism can also be microaggressive. So healthcare professionals may assume that older patients who speak slowly are cognitively compromised and thus incapable of being able to relay their own medical concerns. And so healthcare professionals might not give them the whole story or any story at all. Healthcare professionals might infantilize patients and engage in what's called elder speak, where they speak really loudly and really slowly under false assumptions. Also, when an older patient is accompanied by a loved one, healthcare professionals might direct questions and comments to the other person and not to the patient. So what's the takeaway here? I think we can conclude that elderly patients are a complex patient group. Elderly patients are often multiply marginalized, and healthcare professionals face a genuine, unique challenge in treating elderly patients who often suffer from multiple chronic diseases, lower health literacy, and a number of other problems. And all of this just creates a perfect storm in which moral dilemmas arise. So now the more philosophical part of the talk. What do we mean when we say the word deception? And I'm going to give a variety of definitions here. And these different definitions have importantly different implications. So deception can be defined as any deviation from the whole truth. And this is a very broad definition and one that we likely wouldn't want to accept for a number of reasons, indicated by, I think, all of the other talks. Namely, there are often very good justified reasons for withholding some of the truth or putting off saying something, etc. Deception can also be defined as a deviation from the whole truth, such that one deviates due to intent to lead someone to one's own preferred decision rather than to the best decision for them. So here we can think of leading a patient to try to accept an easier treatment for the provider, which isn't necessarily the best outcome for the patient. There's also the intent to cause someone to have a false view of something that matters to them. So, for example, the outcome of treatment might be more promising than it is, and we might have good reasons for doing that. We might not. There's also the willing failure to prevent someone from having a false view of something that matters to them, or the willing failure to disabuse them of such a view. So, for example, knowing that they won't live much longer, but not dispelling them of their belief that they have lots of time. Finally, there's a willing failure to disabuse someone of a false moral view. So, for example, the view that the patient might hold the view that they have a duty not to be a burden and hence a duty to die. So a number of difficult questions arise, and I think I have the benefit of coming toward the end because a lot of these have already been raised. So I'll just rehearse some of these questions with you. And I'm coming here from a philosophical perspective and not only from a clinical perspective. So what makes deception wrong? Can clinical deception ever be right? And if so, under what conditions? And who's in a position to decide case by case? Are there common reasons that clinicians might be tempted to deceive older patients? So for example, the patient's fear of decline and death, seeing an elderly patient as merely someone waiting to die rather than as someone in a distinctive stage of life with distinctive goods, or the assumption of cognitive decline. So what drives our answers to these questions? And something that I want to suggest is that a driver of deception against the elderly could be ageism, whether explicit, systemic, or microaggressive. And this should concern us. So I want to talk about some moral and other harms of deception. Elderly patients might feel devalued, disrespected, or dismissed when talking with healthcare professionals. And those feelings are fundamentally morally harmful against one's personhood, one's value, and one's dignity. And so this should concern us. There are also harms to the family and care team that other speakers have discussed tonight. So deception that makes life easier for the care team might make life harder for the family and vice versa. We've also seen the extent to which lies can metastasize, and this can be harmful for the entire care team. This can result in moral distress and burnout. So these should also concern us. There are also the practical and medical harms of deception. So failure to include patients in their own decision-making can be a violation of their autonomy, and this should concern us. So the question is, can deception ever be right? And we've seen a number of instances in which it can. We've talked about therapeutic privilege. We've talked, and we had a really interesting discussion last night about do not disabuse orders that we've seen examples of today. Deception or withholding information about someone or something that external rather than the patient themselves. So not revealing information about the death of a loved one, not telling someone about election results, and all sorts of other cases. So the question is, what do we do? And I wish I had a concrete answer in the next slide that you could just take a picture of and put in your wallet and take out whenever you're in one of these situations. But unfortunately, I don't. But here's what I can say. There's no single, simple, or right answer in many of these cases. And Erica has given us a number of ways to navigate those cases in terms of what kind of justifications are necessary. And the particularities of each case matter, and each context matter a lot. I last month experienced a really serious medical condition, and it radically transformed the way that I think about these things on the basis of the treatment that I got from a doctor who I wish was here. And he said something in reflecting on how he treated me. And it seems so simple, but I don't think it is at all, especially in the face of our current medical system and structure. And what he said is that you need to always treat the patient and not the diagnosis. And what this means is to recognize the humanity in your patients, to keep their humanity at the forefront, to remember that they're people, and that individual patients are so much more than their diagnoses. And this, of course, comes into conflict with a lot of the points about ageism and bias and discrimination. And that's a tension that I think we very much have to grapple with on a continual basis. And of course, there's joint decision-making with ethics consults and with your team. So thank you.
Thank you. Our last speaker is the Reverend Ronald Oliver. He is an ordained minister serving as the System Vice President of Mission and Outreach for Norton Healthcare. And he's also my boss. He's been with Norton Healthcare for 34 years. He's the chair of the Norton Healthcare Ethics Council and is an adjunct professor of ethics at Bellarmine University. Welcome, Reverend Oliver.
Good. All right. When Dr. Salter sat down, I said, that was great. My head hurts with everybody. So glad to be here. The hope, an area of special concern. We've all heard the objectives you see here, and we've probably heard it, don't tell him, that he's got cancer because it'll take his hope away. So the question is, does hope sometimes require deception in order to work? Does hope falter when confronted with unpleasant information? Is bad news hope's kryptonite? But to those points, I want to talk about denial, wish, and hope. And this is a 15-minute primer. We could spend more time on that, but here we go. So as they say, as we used to say, I was in the peds ICU for 9 years. Denial, it ain't just a river in Egypt. It is sometimes conscious, but usually unconscious refusal, restriction, or suppression of anxiety-producing information, blocking information about present, future reality. And it's rarely overpowered by more information or more people. We don't beat it down. So the way I think about denial is in Star Trek. I had it wrong, and Rodney helped me. I mean, Star Trek, the Enterprise is out there flying through the galaxy, and all of a sudden the bad guys show up and they're going to shoot proton bullets at it or something. I don't know. What? Torpedoes. Okay, got it. See, okay. They're going to shoot these things. And so what does the Enterprise do? It puts down the shields. You can't see the shields, but they're down. And when the proton torpedo hits it doesn't go into the Enterprise, but it sort of rocks it a little bit, right? That's what denial is. It's the thing that goes but it's automated. It goes out there, and it's to protect the ship, the person, from the incoming stuff that says, if this gets to me, it could destroy me or my worldview or whatever. Okay. So it functions to help us. But what can happen is we can get stuck in it, and that's a whole nother talk that we'll talk about. Wish is something different. The conscious construction of an imagined future disconnected from what is possible. The odds of a wish happening are 1 in a bazillion, fantasy, and it's rarely reframed or adapted. So I meant to tell you that's the beginning, but this is a good time to do it. Because you've shown up here tonight, I'm giving each of you $1 million. I know. This is very exciting for all of you. I know. Next week, you're going to get a check from me. And so go out, spend some money, buy a new car, plan a vacation, go crazy. Okay. Now, I sense a little skepticism. So fair enough. You would want to know how this is going to happen. I hope I'm going to win the lottery. Now, since I don't actually buy lottery tickets, what I'm going to do on the way home from this, I'm going to stop at Thornton's, and I hope I find a lottery ticket floating across the parking lot. That's the plan. Is that hope? That's a wish. You see what I'm saying? So it's silly, but that is a wish. Okay. All right. Hope is the construction of an imagined future in light of what is possible, plus 10%. Because we don't know everything, right? So it stretches a little bit, and it's adapted, and it adapts in light of changing realities, whereas wish tends not to do that. If you go to the Cambridge Dictionary, to want hope, to want something to happen or to be true, and usually have a good reason to think that it might. Hope. So we have denial, wish, and hope. Let me illustrate this in a clinical story, okay? And this is going to be an illustration of hope, and it's going to contrast a little bit with wish. So imagine our imaginary patient person wakes up and one morning says, for about 3 weeks, I've had this thing in my throat. It just won't go away. I need to go get that checked out. So off to the primary care doctor he goes, and the doctor, puts the popsicle stick in and looks around, everything. Yeah, It's probably nothing, but let's get you over to an ENT. He says, well, I hope it's nothing. That's reasonable. I hope it's nothing, right? It's not that it's not something. He's going. So he goes to the ENT. ENT does the same popsicle stick thing and looks around, feels, says, yeah, we need a biopsy. We got to get a biopsy of that. Oh, biopsy. That sounds serious. Probably not, but let's do it. And he said, well, I hope it's nothing, but let's do it. Okay. Biopsy comes back. Used to, you'd wait for the doctor to call, but no, you get a ping chart and you go, I don't know what those words mean, but I do know what the word malignant means. And so you call the doctor and you say, malignant, I hope it's treatable. You see it moved. You see it moving? It moved. Doc says, we got good treatments. Okay, let's do it. So treatment. So there's no denial. We're going through it. No denial. And then there's that tough conversation. We didn't get it. We need to start talking to hospice. And our patient says, I got my daughter who's going to graduate from high school. I hope I make it. You see it moved, right? That is what hope does. It adapts in light of what is possible, plus 10%. Now, to be clear, those are nice little buckets. I put all of those in. That person might be saying, oh, I hope this is, they say hospice, but maybe they're wrong. There's a little bit of denial that gets seasoned in there, right? Maybe they're wrong. We chaplains get called in when there's miracle language around these conversations, right? And that sometimes miracles look a lot like wish. Okay. The important thing when you're trying to assess hope, you're looking to see how well is it tracking with reality, plus 10%-ish. And when you call and say it is malignant, it's perfectly acceptable to imagine denial, that force field going into place. But you're wanting to see that it moves out. So I want to talk just very, very briefly about Erik Erikson's, reach way back to your psychology days. Thank you, Tammy. Make me feel old. Theory of psychosocial development. And what he says is the very first stage in psychosocial development that babies up to 2-ish are trying to figure out is this world a safe place? Am I safe? And if it is, that I can trust the environment, I can trust the people who are taking care of me. And if not, and I mean systemically not, then mistrust sets in, right? And he would argue that begins to set a trajectory for the way one develops. And what he goes on to say is, if trust is established, then the capacity, the virtue of hope emerges, right? But if it's mistrust, the maladaption is withdrawal and insecurity. Now, take that lens and put it on a therapeutic relationship, right? So the mistrust that's going on between the provider and, let's just say, the patient and family, I'll just say the word patient. If there is trust, then the capacity for hope exists. But if there's mistrust, I've seen it more times than I can count, and you probably have too, the withdrawal. They start limiting who can talk to the patient. They start limiting who they want to talk to, or who's going to be the spokesperson. The point is, trust is very valuable, not only to the therapeutic relationship, but to hope as well. So let's talk about some guidelines generally, okay? Let's see, I think the obligatory statement for all the speakers is, I'm not going to give you an answer, okay? This is directionality. This is things to think about. So first, patients get to choose how they hope and what they hope for, okay? Now, I'm not saying wish or stay in denial. I'm talking about hope, right? So I hope I get to make it to my daughter's graduation, right? Or maybe it's something else. We have Make-A-Wish, and where people do things because that is meaningful to them. So we're going to err to the side of embracing the things that patients hope for. As we've talked about, some patients are really okay with their denial or their wish. Ignorance is bliss for some people. I don't want to know. I've heard, I do not want to know. Tell them outside my room, I don't want to know. And I think we've covered that. Some patients will appoint information gatekeepers or managers. It's but I should have put it's problematic for others, family or clinicians, to decide what is good or bad for a patient's hope. Don't tell them because it's going to harm their hope. So my wife's sister was diagnosed at age 29 with glioblastoma, pointing to a brain tumor. After her first surgery, the surgeon came out and said to the family, don't tell her she's got this bad cancer. It will take away her hope. Amy dies. And her mother, with tears, says, I talked to her about everything but her dying. You see? Okay. I get the good intention, but it came at a cost. And everybody knew. Right? There are some times when the clinicians and others will have to manage the strain imposed by truth. So are there situations when the patient is been in a car wreck and they're on medications and their head injuries, and they have a moment where they wake up and they say, how's my girlfriend who died in the wreck? My belief is that they lack some capacity to integrate that and to be able to handle it. They're too vulnerable. So the delay, the deflection might be more warranted. More guidelines. When denial or wish impede reasonable treatment considerations or decision, an intervention may be warranted. And the word intervention there is in quotes. Denial or wish are seldom breached with compelling knowledge and messengers. So I've been in the room, and this is early in my career, and I just don't feel good about this, but we were sitting in the Peds ICU conference room, and the parents weren't getting it. You know, it's the old saying, if you're not anxious, you don't know what's going on, right? So they weren't getting it. And so all of the specialists laid out why it was worse than the parents understood or were feeling. And by me being there, I participated in that. So I'm not saying they. And the ironic thing is the parents got happier. So afterwards, I talked to them and I said, what did that mean to you? What did you hear them saying? Well, we thought he was sick. We didn't know he was that sick. And we're going to have a miracle. It just means we're going to have a greater miracle.
Wow.
It didn't puncture it at all, right? So change, if and when it happens, typically does so in the safety of a relationship with a trusted authority, somebody that means something to them, and typically requires the extravagance of time. That's what hospitals are known for. Slow, deliberate, thoughtful, sit down, let's know. But you have to think crock pot, not microwave. Okay. So how does that conversation happen? So back to our questions. Does hope sometimes require deception in order to work? Very, very rarely. I'm not saying never, but very, very rarely. Does hope falter when thoughtfully confronted with unpleasant information? Typically, no, it adapts. When unpleasant information, contrary to a patient hope, needs to be conveyed, err to a slow reveal so as to titrate, hospital word, just right, titrate with the information with the capacity of the fiber of hope, the ego strength of the patient, and the reliability of the support network. Okay. So that in my tradition, we bear one another's burdens and that there's someone there to help them bear that burden. In Dante's Divine Comedy, 12th century, the gate into hell bears an inscription ending with this phrase, "Abandon all hope, ye who enter here." The absence of hope is a definition of hell. So we don't want to destroy hope. We want to help it adapt to the situations that the patient is facing. Oh, zeros. Time to sit down.